All right, it's showing 11:03 on my side. I would actually like to start because we have so much to cover today. So, good morning, everyone. For those that do not know me, my name is Khalid Kazi. I am one of the paramedics at Mount Sinai EMS, and also an assistant professor for the Borough Manhattan Community College paramedic program. I see quite a few names on the attendees list of folks that have attended our sessions in the past, so welcome back. And to those that are attending for the first time, welcome. We're really excited to share some great information with you guys today. And I would love to be able to really sort of explain what this is all about. So for those attending for the first time, Mount Sinai EMS and in partnership with Mount Sinai Selkoff Centers for Occupational Health and also the BMCC Paramedic Program, we have been working towards industry improvement within the EMS space, and more importantly, how do we protect our providers that are out there? And when we talk about protection, that can fall under a bunch of different umbrellas and buckets, but protection from our patients, protection with our mental health. So for today, we're going to vector in onto a couple different topics, especially within the space of lifting and moving. So protecting our bodies, situational awareness, and things of that nature. So I'm very excited to be working with a great group of presenters that we have today. We have Arlette Lauser. She is an ergonomist and a physical therapist for the Mount Sinai Selikoff Center. We have Michael Gormley. He is the clinical nurse manager, does a lot of work in the upstate regions and here within New York City. And then we have the wonderful Dr. Yelena Globina, who is the physician that is overseeing a lot of these projects. And we are relying on her today to provide some great expert advice on the case we will be reviewing. So, just to explain sort of the setup that we have today, our setup will be a case study, and then we will move forward in discussing the safety components to it. So, I'd love to hand this over to Dr. Globina.
Good morning, and thank you so much for this opportunity to speak to you about how to um, prevent injuries and do what we do at Selikoff, which is keep workers healthy, prevent injuries, and keep the workplaces safe. My colleagues and I work at Mount Sinai Selikoff Centers for Occupational Health. And there we see injured workers, workers with toxic exposures. And the goal and the ultimate mission of our clinic is injury prevention, first and foremost, proper diagnosis, proper treatment, and assisting all the patients that come through our doors with workers' compensation benefits or employer covered services when necessary. Next slide, please. So today, I will begin by setting the scene for a case that resulted, unfortunately, with an injury to one of the responders. I will pass it over to my colleagues who will talk about specific ergonomic exposures that were high risk for injury during this particular case. They will talk about proper incident reporting, safe patient handling, situational awareness, and injury prevention. Next slide. So to set the scene for our discussion, I would like to describe what happened to a crew of emergency medical providers who responded in New York City to a call that was to assist an intoxicated patient who was 3 floors below ground level that required 3 different staircases to navigate by the crew to get to the patient. The patient was in stable condition, but heavily intoxicated and unable to follow commands. The EMT crew that consisted of 2 emergency medical providers placed the patient in a stair chair, Next slide, please. And the stair chair that they had used specifically was a type with a track system. They secured the patient to a chair, and together with everything, the patient weight was about 190 pounds. In addition to this weight, that the crew had to navigate up 3 flights of stairs now, was the EMT1, who had a total weight of 40 pounds, that consisted of an airway bag, and various other equipment to secure airway. And EMT2, who had a total of 50 pounds on him, that basically consisted of all the equipment necessary in the trauma bag. And as they moved up the stairs, the two emergency medical providers were facing each other, because that was just what was more comfortable for them. And unfortunately, during the maneuver, the patient had slumped over to the right side. In order to maintain balance, the first emergency medical technician shifted his entire body with the bag to the left. And then the emergency medical provider, who was at the bottom of the stairs, was trying to maintain a neutral position, as the EMT at the top of the stairs was regaining balance. Next slide. So unfortunately, due to this shifting of the weight to maintain patient stable, the first emergency medical provider developed sudden left shoulder and sudden left lower back pain, was subsequently continuing to provide the patient care that was necessary. And after the patient was triaged, the emergency medical provider that was injured spoke with their supervisor and was advised to fill out an incident report and present to the emergency department for the evaluation. There, they were diagnosed with muscle strain to both body parts, the upper extremity and the back. And they were advised to rest for 2 to 3 weeks while getting physical therapy and recuperating. So I will pass on further discussion to my colleague, Arlette Lozier, and thanks.
Good morning, everyone. Before we jump into analyzing the case, I think it's a great opportunity for us to realize just how many EMS providers are impacted by injury. We don't have, unfortunately, we don't have anything more up to date in terms of data on injuries from 2017. But what we do have from that time is that more than 20,000 EMS workers were visiting the EDs for work-related injuries. And besides the fact that that's a huge number, and we can imagine that that number is actually larger because that does not include visits to their own personal providers or going to an urgent care or employee health services. The other thing that's important to look at is who's getting injured, a little bit more detail, granular. So what the findings were at that time is that it was workers mostly who had less than 10 years experience and were working full time. So we need to pay attention to that and training and confidence out in the field. What types of injuries, as you would expect, most were sprains, strains occurring to the back and the neck. Although we do see each year it flips a little bit. Sometimes we have a few more knees. And we also have a host of shoulder injuries as well. And these were providers that were responding to 911 calls for the most part. How the injuries occurred, of course, exposures, to bloodborne pathogens with needle sticks, body motion, physical exertion, slips, trips, and fall. There are motor vehicle accidents, and of course, we are talking quite a bit about violence and patient assaults. So going back to the case that Dr. Globina introduced, it's good for us to dive in here and to look at some of the details. What really happened? What from the case specific job exposures? What happened that we should be paying attention to? So we had an unpredictable weight shift of the patient, which caused EMT1 to compensate. We have the movement of the equipment bag on the EMT, which then is the secondary challenge and exposure, because once the EMT moved to compensate, the bag went along with them in that direction, and then they have to compensate and stabilize their body even more. So it impacts on their body posture. Then we have other potential job exposures, like the coordination of partners to negotiate steps while carrying a load. We know that you do this quite frequently. We also know that it's hard. It's very demanding, and each case is a little bit different. Each staircase, whether it's a subway, whether it's a private house, or a basement, or going up the stairs, or an office building, or even a yacht that may have a circular staircase, we know that the coordination of the partners and the communication is really key. And if it's not solid, then we can have risk. What happened at the bottom of the staircase for EMT2, if someone is carrying the load and stabilizing, they can so easily be pushed off or pushed over if the stair chair alters the position. So that's an exposure for the provider that's at the bottom of the stair chair. And then, of course, it's a higher level of physical demand because it's a sustained muscle contraction. They are stabilizing that stair chair. They're holding it as much as they possibly can. It's physically demanding. That's an exposure. The muscles do fatigue. At the top of the stair chair, when we talk about EMT1, they can be pulled either backward or forward, depending on which way they're facing, and that creates risk. If they are going up backward, they have unseen terrain, right? They don't know, certainly we'll talk about best practices and counting steps, but they don't know what's behind them if it's just the two of them. Until they get to the next landing, and they can be pulled forward if they're facing the patient, and certainly that's a risk as well. And then if they're facing away from their partner, that's what I was making reference to, without having the visual field of the patient and the partner. That is another area for risk and is a job exposure. And then what we do is, as an ergonomist and a therapist and someone who looks at injury on a daily basis, we're clear that personal risk is layered on top of the risk of the job. So what does that mean? It's the predisposition for the injury. It's the level of experience, as we saw in the data, that impacts on frequency of injury. The body type that someone has, which, of course, this is not something that we can control, but it's important for us to notice. Are you fairly flexible? Are you very flexible, hypermobile, where you may have a predisposition for injury, and what you can do for compensating for that? Are you lanky? Are you more muscular? Are you top heavy, bottom heavy? All those types of features of a body, characteristics, are what we look at to assume personal risk in order to assess. And then what I have starred here with asterisks are the injury history. Have you ever been injured before? We know that injuries do get repeated. We know most often they're considered the weakest link of a body because either the injury has left its mark on a body in terms of scar tissue, in terms of compensation for how someone moves, or maybe someone has stopped doing their exercises to stay strong from an area that's been injured. And also, what's the physical condition of the provider? Is someone into physical activity? Are they more on the slothy side, where it's like, I just got to get home and rest? But how does the body perform, and how does that create a personal risk for someone? And of course, we cannot do this presentation without talking about the stress level that's involved and the lifestyle. So all of these aspects, these characteristics, layer on top of what the exposures are that we touched on with the case. So we're doing an informal poll, and if you could put into the chat if you've ever sustained a strain or an injury on the job, and Khalid is going to collect some of the answers for a moment. And have you missed a day or more of work because of a strain on the job or an injury? If you could just pop it into the chat. Some examples may be back strain, neck spasm, ankle sprains, just whatever you remember has happened during the course of your career. I see a couple of you have put in something. Khalid, maybe you can share with us.
Yeah, so I feel like unfortunately a lot of us in the EMS will suffer something. So me myself, I've definitely had a right shoulder strain from trying to balance a monitor and transferring a patient. And I also suffered rolled left ankle as I was trying to balance myself moving a patient on a longboard. And we are getting a good amount of responses out there. So we have back sprains, neck sprains due to an assault, unfortunately. So sorry to hear that. We have someone currently out injured. We had someone that had a hernia. Yep, that's definitely a big risk there. And I want to thank Arlette for teaching me about tightening my abs when lifting. So we'll be going over things like that. Don't be shy, folks.
Okay.
Okay.
This is helpful because as we talk a little bit later about acknowledging incidents and reporting, it really does help to make things better and to acknowledge that there's a void of education of what we can certainly do to support you in terms of injury prevention. So thank you for sharing that. So let's go back to our case again. And of course, we will see lots of things out in the field. And it was, in a good way, a challenge to put together this presentation because we do know that best practices are relative to where you work, your personal experience. So we want to share this, and in a perfect world, we'd have a great discussion group about this. But first and foremost, we do recommend that you follow the manufacturer guidelines of the stair chair, no matter which one you have, and also what the guideline is, your policy of your particular department or your group, so that you are following protocol. And these are great conversations to have, when you go back after looking at this case. Partner communication is a best practice. It's essential. Stair counting to the landing, whether you're going up or going down. In this case, in our case here with the 3 flights, they were going up, which is so difficult in terms of the load. So we want to determine who's going to make the count. Usually when you're going down, it's the lower EMT that will make the count because they're the one that really has to navigate either backwards or forwards, but they're the first one to land, so they know how many stairs there are. And then going up as well, there is a count, but usually it's the upper level EMT. Now, you may find in your department you do it a little bit differently, which is fine. It really has to work for your group and based on what your guidelines are. The hope was that there would be only one best practice, but the truth is that what we see when looking out into the field and at the equipment recommendations, that it's not always the same. Partner communication is also so helpful if one of the partners needs to take a pause for muscle recovery. Sometimes it's just a rough day. If you look at this provider over here and you look at the degree of flexion back here, so his shoulder is coming back into extension. He has a very tight elbow angle. That is not a neutral posture. That is not optimal. So it is tiring. It is difficult. Then you have the EMT up at the top who has their arms straight out as they're pulling up the chair. One of the recommendations that we make in the world of therapy and ergonomics is not to have your elbows in full extension so that your muscle is not on full stretch and has a better contraction. We like to aim for neutral, which is kind of the midway of the muscles. Another piece of best practices that I love in this picture, unfortunately, they had 2 more people there, that there is a provider behind the lower one holding the chair who's able to give cue and have a hand on the back there. They're not pushing them, but they are cueing them. They have a hand there just so they know they're secure. Hard to tell if they're going up or going down. But that's also, if you have a third person there, you do want someone to be able to contact guard, if you will. Some other best practices that we want to share are looking at, who's at the top point and who's at the bottom point of the chair. Oftentimes we'll put the taller person with the longer reach at the top of the chair, not only because they can get a better mechanical advantage, but also because their feet are less likely to get hit by the chair because they have more length, and so there's more stretch ability. Of course, we're not looking for them to overstretch. And then, we also want to talk about, well, who's going to go up? Who's going to be the person with the stronger body strength, upper body strength for the lift? And going up steps, oftentimes we'll put that person at the top. But again, this is a conversation. Counterbalancing the stair chair when you're making turns, so much communication, so much of a distinct language to use. Okay, we're going to tilt right in order to make this turn to the left so that we can create the space at the landing. Or sometimes we don't have the luxury of an L-shaped situation, right? It's a much tighter turn and you have to make a U. So that kind of language in discussing when you go back to your places of employment is really key so that you can have a universal language. So really what it comes down to is, what is your practice? And this is the discussion point that we encourage you to take back to work and to have these conversations so that when you have to negotiate stairs, and hopefully it's not 3 flights in the subway, but that is one of the realities in New York City, that you'll be able to feel more confident when you have to navigate that. There's so many chairs out there. These are just 4 examples. Really, it's not about the manufacturer. It's really about the type of chair you have available to you. And we know, after speaking to so many providers, that there are different chairs available to different companies. So you may have a chair with track, you may not, you may just have a simple folding chair. Whichever one it is, competency and comfort is really key. And what goes along with this, once you've looked at the exposures, you've looked at the best practices, then you have yourself, then you have you to ask, well, what happens if I do get hurt? What happens if I'm injured? How do I know how severe an injury is? We share this part in addition to just talking about the case, because at the end of the day, we want, the goal of this program is really to enable EMS providers to work as long as they want to, wherever they want to, for as many hours as they can or want to. And you want to be able to take care of yourself. Self-care is key. So knowing and getting a sense of severity of an injury or a pain or an ache. And I know a lot of people try to tough it out and not to go for physical rehab. That could be a game changer in terms of longevity of physical strength and also having a program to compensate for an old injury. And then also really preventing a reoccurrence of the injury is what we're aiming for. So the early intervention is key, and we encourage you to do that if you see that there's anything that you're concerned about, or if a pain doesn't go away at night or on the weekends. That's telling you something. Also, we want to talk a little bit about incident reporting, injury reporting. In some places, I know that providers don't even want to talk about reporting. We want to encourage you to do that so that it can really highlight what the areas of risk are to your managers and to leadership, and really so it can be addressed for system improvement. The incident reporting really does help to protect employees in the long haul because we can go back and do remediation, and we can also make changes. We can recommend changes. And it does reveal patterns and trends. And if we see that something's going on and something has changed, it's important to pay attention to it. But the only way that administration knows what's going on is through conversation, communication, and incident reporting. So the question is whether you know your organization's guidelines, if you're totally comfortable with that. If you're not, please go back and make sure you're really clear. What do you do if? What do you do if it's a minor injury? What do you do if you don't not sure you're injured, but you're just having pain and discomfort? And the question that I love asking, and there really is no one answer because we do not have research on this, is your physically demanding job making you stronger? And I'll bet if I put this out as a polling question, I would get so many different answers because the perception for many is, yes, every day I'm out there, I'm getting stronger, I'm using the same muscles. And then others are, every day I'm out there, I'm so tired. I feel like I'm using everything that's in my muscle bank. So it's a really important question to address personally. And if you're not really feeling strong, to make some choices about what you want to do to become stronger. We are an occupational health clinic. We do encourage workers to really do whatever they can to take care of their bodies, no matter what they do for a living. And certainly in your line of work, as an EMS provider, was a highly physical job, aerobic exercise, even a small amount, and regular stretching and strengthening and personal self-care are all key, because physical fitness improves physical and mental health, and it will help to prevent injuries. At this point, I'm going to turn over the presentation to my colleague, Michael Gormley, who's going to start talking about situational awareness in the field. Michael?
Thank you, Arlette. Yes, as a former 6-year EMT and current ER nurse, also working with the Celico centers, we get many injuries in the field. Some of them are avoidable, some of them are not. But when we get to a scene, first thing we need to do is assess. And if it's an aggressive patient, you assess the aggressive situation before getting involved. Determine the degree and cause of the aggression. If it's drunk, if it's an injury, if it's a previous injury that the person has had, like a head injury from combat, from a car accident and that, and they may be agitated when their situation gets a bit out of control. But the main thing we have to do is we have to know when to back away. We have to know when to get out, steer clear, and wait for help or call for help. So keeping that in mind, we must train on frequently needed skills, CPI training, basic self-defense, anything like that. Go to the gym, work out, lift weights. But a black belt in karate may save you on the street, but not in court. If you do happen to have a black belt and you take a person down and they get hurt, it could come back on you. So we need to never try and use that. Also with communication, when we're talking to the patient, we have to demonstrate appropriate behavior in the moment. We can't let them agitate us. We can't let them goad us. We can't let them goad us into pushing, or they can't push us. We are the ones that are controlling the scene. We must follow our institutional guidelines. They have protocols for many incidents out in the field. Follow them, read them, know them as much as you can. And physical defense should not be viewed as an assault. So what I'm saying about that is basically, if you are trying to defend yourself, and there's always cameras there, that when you do what you have to do to take the person down easily, that it should not be viewed as an assault. So we're going to use the least amounts of physical force, because you will be on Channel 5, you'll be on one of those news stations with this EMT took a person down and hurt them. So that's what you want to stay away from. And documentation, the most important part. You're documenting and defending your actions. Note the date, time, location, contact info of witnesses, bystanders, other responders, police, anyone who's there. Also note that there's cameras in the area. If a camera can pick up what happened, it may be to your defense. Next, please. So what we're going to talk about is some de-escalating techniques. always introduce the crew when you get there. My name is such and such, I'm paramedic with such and such. I'm here to help you. Can you tell me what's wrong? Explain your presence. Why are you here? You know, we got called because your family member was worried about you. Said your ultraviolet status. You fell, you hurt something. Can we take a look? Listen to the patient. If they can talk to you, let them tell you what is wrong. You don't just assume that it's like, okay, you know, they fell, hurt their leg, and they're holding their knee, but it could be their hip that's gone. So we let them tell you what's going on. And be mindful of interpersonal differences and language. We have interpreter applications that we can use. Feel free to use them. Because if you have a person say a smile in some language, maybe an insult, eye contact to a patient, maybe an insult. So we have to basically try and work with the patient, see what is going on with them. And the crew member who has the best rapport with the patient should be the one that's dealing, not the it may not be the crew leader, it may be the driver, it may be anybody on the crew that has a good rapport with the patient. And we don't want to escalate the situation, so let them be in charge. Let them talk to the person. You know, we do our medical stuff, but let them talk to the patient, explain what's going on. Do not use profanity. Maintain professionalism at all time. You are there to represent yourself, your profession, and your core and your company. Please remain, keep professionalism at all times. And again, explain your processes using clear language. Move slowly and deliberately. Older people can get scared if you walk up to them, kneel down, and they see you as a threat. They're going to back off. They're going to shut down. And also know when to back out. If things are going bad, know when to back out. Do not let anybody between you and the doorway. If someone's working their way around you and you catch it, back up, back to the door. Make sure that you bring your partner with you. Explain why you're leaving, or if you have some sort of a code word that you use to get out. If the situation's going bad, use it and leave. You have a radio, you have a cell phone, so it can have PD, fire, and EMS units within earshot and radio contact. Call for backup. Next, please. So, situational awareness best practices. Know your location and the address, where you're going. Don't be, as often I'm working down New York City and I see an ambulance responding and someone sitting watching YouTube or on their phone. When they get there to take action, know your area, know where you're going. Make mental notes of buildings and map your travel route. As a former psychiatric tech, I use mirrors, shadows, lights, everything when someone was walking behind me. And I was never hit from behind because I always knew where the person was. Use whatever you have. Know how to navigate out of the area. If you're making 3 rights, you're going to make 3 lefts on the way out. Use landmarks, odd colored doors, railings, plants to guide your egress. So if you're going up 4 floors, you know you're going to press 4. And if you have to run down the stairs, you know which is the basement floor. Don't let people get behind you, like I already said that. That's very, very important. And keep the exit door between you and the patient and family. Do not become separated from your partner in a critical situation. Stick together. If there's a situation where one person has to go to get something and the scene is okay, that's okay to do it. But if you are together and something goes awry, bring your partner with you. Leave the equipment behind if necessary. It's insured. It may get broken, but it's insured. Next, please. So let's talk a little bit about ambulance safety. They've gotten a lot better since I was riding on them. More handles. We've better entry egress. We have the kneeling ambulance is the one which come down with the airbags, which will drop down to the floor. Wait until it comes down. Wait until it rises up before you take action. Use the handles. We're going to talk about stops, sudden stops and acceleration. Sudden stops when you're working in the back of an ambulance. You got to have a seatbelt on. You got to make sure that you're safe. Your face will fit between the dashboard and the front of a Ford ambulance. Been there. Wasn't pretty, but I made it. When you're reaching for equipment, make sure that you're steadying stuff with one arm, one hand, or you have to sit on the ground. If you have to sit, then sit. Patient care while the ambulance is moving. You may have to put a IV in, 12 lead, whatever you may be doing on the patient. Putting oxygen on. Let your partner know so they can slow down a little bit. If you're going to the hospital, it's not code 3, and you don't have to fly through traffic, brake, accelerate, and leave the person in the back throwing up on the patient. Also, patient's mental status. If they're drunk, and you've seen sometimes what drunk patients can do, they'll grab you, they'll try and hit you, they'll try and get you down close to their face so they can headbutt you or punch you. Keep a safe distance away from the patient. Don't let them get the opportunity to hurt you. They may have something in your pocket. If the police give you the patient to transport, it's a psychiatric patient. They may not have searched the patient thoroughly. They may have something in their pocket. And we saw that one of our EMTs some time back got hurt. It happens a lot. And so moving, lifting, and patient handling. So it's always assessment. You assess the area when you get in there. You observe the totality of the surroundings. It's basically situational awareness. Make sure that you know where you are, how many stairs, what's in the apartment, if it's cluttered, if there's something going to fall on you, if there's bookcases that are leaning against a wall in a bad place, so you may touch them, they may fall on you. Communicate with the patient, assess their mental status. Physical assessment head to toe, of course, we don't have to tell you, but that's already what you know. You do your physical assessment and determine the patient ability to assist. They may be able to walk to the ambulance, may be able to walk to the door. You don't have to bring the stretcher in to put them on. So you assess with the patient what their capabilities are, and you determine the transfer type from there in. What challenges do we have? Removal from tight, awkward spaces. We know when people fall and they're overweight, they always fall between the bathtub and the shower, the bathtub and the toilet, and they get jammed in there. Call for backup. Vehicle extrications, one of the most dangerous things. Unstable vehicles. You see the videos of cars moving when the firefighter is working on the door slips, breaks, and the firefighter gets trapped. We have A, B, and C posts when we cut them. It's sharp edges. Some fire departments use cut-off older hoses that they can put tape on the A, B, and C posts, and put a jacket on it. Make sure that be careful of cuts. You don't know what kind of bloodborne pathogens has been spilled on this car. So always check when you're done. Wash your arms. Wash your hands when you're finished. And drops, slips, trips, and falls. Wait for the winter. Winter's coming. So scope your path. Identify challenges and communicate. Inner cities, broken sidewalks, manholes, uneven surfaces, anything like that can cause you to lose balance, can cause the stretcher to fall over, especially if it's an overweight person. It can hit the ground. It can be hurt. You may get sued. So slippery surfaces, ice, rain, soap, especially it's going to rain next couple of days and it hasn't rained in quite some time. The streets are going to be very, very slippery. So when you're driving, drive slower. And the lead looks while the partner moves. So basically, the lead is the person pulling the stretcher and the partner is the one steering from behind. Watch what you're doing. Don't let the stretcher go. It will take off, as you know. And you know what happens from there. And avoid spinning the theme. Again, we said avoid spinning the theme. Very, very important. Next, please. And this is, I think, my last slide. But however, other environmental considerations, driving and terrain negotiation. Exercise due regard for prevailing conditions. Do not run red lights. Stop at every light, especially in city areas. And we hear every year, every week, every day that someone gets hit, and a bicyclist gets hit by an ambulance. I think it just happened in New York City. They're making a left and someone is crossing. You see little old ladies walking across. They may not hear you or see you. Don't assume that they'd always see you. Sometimes they won't. If they're wearing headphones, or if on those electric bikes, they come in either direction. They'll go up the street or down, so it doesn't matter. They want to get where they're going. So just be careful of that. Stop, look, and move. Black ice and rain. We also talked about that with slippery surfaces. Also, motorcycles, bikes, pedestrians, and runners. Again, due regard. If your partner says stop. There's something there. We'll go down to low angle surfaces. Big problem when you sit down a hill. It's not a high angle, so it doesn't need a high angle rescue team, but you may need a crew to help you bring the stretcher up. Low angle could be on a street, could be on a lawn, could be anywhere. Wait, get some help to bring the person up. I think I've done all right. Going to hand back over to Arlette. And thank you.
Thank you, Michael. So as we come to the end of today's webinar, really we want to collect all of this perspective on safety and really to start the conversation about building a safety culture, peer communication on the job. We really encourage you to go back to your teams and to have conversations about how you can be even safer. What projects, what initiatives can you take on? Even one change of practice can build a safer team. And the awareness is really what we're looking at. So if it becomes a group initiative, then with commitment, then there can be fewer incidents and fewer injuries. We also, talk very often about near misses. What happens if you almost get hurt, if you almost fall? These near misses are tremendous learning experiences, and bringing those types of situations without necessarily having an incident is a wonderful way to decrease risk and exposure and to decrease the chances of an injury. So bring that back to your leadership, to your managers. Continued education on injury prevention. We are very happy to have this program and to share it and to come on site and to work with all of you on injury prevention and other aspects of it. We do simulation groups, we do in-person training. We know that the more training and education we do, the better off all of you will be. And the fewer patients we'll have stepping into our clinic, which is really the way we want it. We want to support our patients, but certainly we want to try to prevent the injuries. So speak to your managers about concerns as they come up and ask questions, share your own challenges. We go back to that stat about less experienced EMS providers, having the highest level of injuries. That's a great way to have conversations to increase the learning and the comfortability with best practices. So this program, we started it in 2019. We continue to grow it and to expand it and to evolve it, different media, using webinars, coming in person, plans for other educational ways to impact the field. We know that there's a void. We know that it's missing for what it is as injury prevention. We want to help to build your confidence and your knowledge as a first responder in self-care. We want to help to increase awareness of injury risk and to continue to look at solutions with you. We don't do this ourselves. We team with each one of the groups, the providers. We've teamed with Mount Sinai EMS and other groups up in Westchester and volunteer organizations in order to come up with solutions that work for them. It's not about us. It's really us bringing the expertise to work with your expertise together and to team and to come up with solutions and to share the strategies for daily practices with each other. And also, what really rises to the top that we talk about all the time is destigmatizing reporting on the job injuries and incidents. Don't be afraid to report. It can only make things better. I know there's always a hesitation. It doesn't mean you're weak. It means that you're trying to make things better and to take care of yourselves. So with this, I'm going to ask everyone to take a very quick 3-minute survey, if you can scan the QR. And at the same time, while you're doing this, if you have questions, to please enter them into the chat. And Khalid will moderate any questions that come up that we can help you with. And certainly if it's not something that we can answer right now, we will get back to you. So, please feel free. We love communicating with our attendees after the webinars. We feel that it's an ongoing discussion. So please don't hesitate. But the survey for the CME, it's 3 minutes. It's very quick. So please do that. So I'm going to hand this over to Khalid.
Great. Thank you for that. And on the screen right now, folks, if you would love to get more information or even see if our presenters today can arrange a workshop at your local agency, please do not hesitate to reach out to the Selkoff Center. Their numbers up there along with their social media information. And I'd love to just add to this that this partnership sort of happened. I wouldn't say by accident, but without my prior knowledge of the great work that Selikoff does. I was formerly the training and safety manager for Mount Sinai EMS, and one of my tasks were to identify ways to bring down our injury rates. So I did a little bit of research. I sort of cold called Selikoff, reached out to Arlette out of the blue, and I was extremely impressed with how fast that she responded. First off, that's unusual to me in a corporate health setting, and then more importantly, how dedicated the whole team has been into really trying to figure out ways to improve our lifestyle here within the EMS field. The running joke culturally for us, paramedics and EMTs, is that we're sort of like stepchildren. We're sort of forgotten. I can say during my time at Mount Sinai, that wasn't the case, at least from the health system level. And Selkoff is proof that there are folks outside of EMS that are looking for ways to really help us do a better job. And when I say better job, not just clinically, but also in such a way that we can turn this into a career and actually retire out without missing body parts or replacing body parts on ourselves. So I do want to always thank the Selkoff Center group for really taking this project under their arms and carrying it forward. And as Arlette mentioned, it started in 2019, and I always tend to forget how fast time flies that we've known each other for that long. And every other week or every other month, she would always reach out, check in, and and always looks for ways to improve the program and to grow it. So your feedback, especially through the survey, reaching out to Selikoff directly, or you can even shoot me an email. It's extremely valuable because it really will help us determine what's the best way we can deliver this information to you folks. So please feel free to throw in a question. We still have a little bit of time, so I would love for folks, if there's anything tickling your brain about safety, about best practices, feel free to ask. I see your hand up from before, John. I'm not sure if you ever got a chance to throw the question in the chat, or if you'd like to unmute yourself, feel free to do so. All right, Arlette, I don't want to torture our participants. I got the casual thank you from one of them. So uh
Sure.
but the contact information is up there, folks. So please don't hesitate if something pops in your head after we leave. Please just reach out, let us know, and we'd love to be able to bring this program all over the state and potentially the nation.
I do want to mention just one thing in closing, that today's safety case review is actually one in a series of three. We will be doing a different case review, a safety case review in the wintertime, come January, February. And then we will also be doing one in May for EMS week. So you will see us again, and you'll be getting our flyer since you signed up for today's workshop. So we're really glad you came, and thank you.